Hello everyone, this is a last minute review of viruses, fungi, and parasites. My objectives in this presentation is to discuss high-yield effects, focus on buzzwords and key points in clinical vignettes, discussion of viral, fungal, and parasites high-yield points. In unit presenting with vesicular rash, fever, seizure, abnormal liver function, abnormal CSF findings, DIC, and negative bacterial cultures, what is the most likely cause? Neonatal herpes simplex virus disseminated infection. Diagnosis of neonatal herpes simplex virus infection by culturing all the lesions for herpes simplex virus and confirmation of the diagnosis with fluorescent antibody staining or enzyme immunoassays, and for CSF herpes simplex virus PCR. If neonatal herpes simplex virus infection suspected in any neonate, IV acyclovir must be started immediately without waiting for lab results. If you have a child presenting with fever, gingival swelling and bleeding, blisters on the lips and gingiva, drooling because of pain, and looks dehydrated, what is the most likely cause? Herpetic gingivostomatitis. High fever, poor feeding, severe throat pain in older children, drooling, very small vesicles, and ulcers in both tonsils. What is the most likely cause? This is an enterovirus infection causing stomatitis because of ulcers in the back of the throat. You may see Herpes angina in the choices, you may not, so be familiar with this name. This is enterovirus, subtypes Coccidioidomycosis, so be familiar with all these names: Herpes angina, Coccidioidomycosis infection, or enterovirus. Stomatitis can be with or without rash. Fever, vesicles, and ulcers on buccal mucosa and hard palate, tongue. Erythematous maculopapular rash all over the body, petechial rash on the palms and soles. What is the most likely diagnosis? This is hand, foot, mouth disease. Be familiar with enterovirus infection with exanthem. You may not see hand, foot, mouth disease in the choices. This is an enteroviral infection. If you have a child presenting with fever, runny nose, cough, hoarseness of voice, diarrhea, and pharyngeal exudate, what is the most likely cause? Viral pharyngitis. The treatment is supportive. If you have a child presenting with eye infection, conjunctivitis, and oxidative pharyngitis, rhinorrhea, cervical adenitis, and fever, what is the most likely cause? Adenovirus infection, or well known as pharyngoconjunctival fever. Throat pain with petechiae and oxidative pharyngitis, fever, headache, large cervical lymph nodes, splenomegaly, atypical lymphocytosis. The patient developed rash after was treated with oral amoxicillin. What is the most likely cause? EBV, infectious mononucleosis. Best screening for suspected EBV infection: heterophile antibody test. This test is not reliable in children younger than 4 years of age. Instead, order IgM EBV antibodies or EBV PCR quantitative in children younger than 4 years of age. Infant presents with 3 days of high fever, febrile seizure, develops rash when the fever resolves. What is the most likely cause? Human herpes virus 6 infection. Also, this condition is called exanthema subitum or Roseola infantum. Be familiar with these 3 names when you have a child presenting with high fever 3 to 4 days with non-specific symptom like runny nose or a mild cough and possible febrile seizure, and when the fever is gone, the rash develops after. This is a classic presentation of Roseola infantum. Fever, headache, runny nose, rash on the cheeks, looks like slapped cheek, and a lacy-like rash on arms and legs. What is the most likely cause of this condition? Parvovirus B19. This condition is well known also as erythema infectiosum or fifth disease. This child is not contagious anymore and able to go back to school. Generalized pruritic vesicular rash, varying stages of development, papules, vesicles, pustules, crusts, low-grade fever. What is the most likely diagnosis? Varicella zoster virus infections, or well known as chickenpox. How long is chickenpox infectious? 1 to 2 days before the rash and until all lesions are crusted over. 4-year-old comes with painful and itchy grouped vesicular skin rash. What is the most likely diagnosis? Herpes zoster or shingles. The treatment is supportive by most of the experts. Mother had onset of chickenpox within 5 days before birth or within 2 days after birth. What to do next to protect this baby? Varicella immunoglobulin IM or intramuscular should be given to this infant to provide protection or passive immunization within 10 days of exposure. If the mother had zoster, not chickenpox, the immunoglobulins are not indicated for this case. Very high fever, cough, coryza, conjunctivitis, bluish-gray specks on the buccal mucosa, maculopapular rash spreads from the head down, splenomegaly, and lymphadenopathy. What is the most likely diagnosis? This is a classic presentation of measles or rubella. If you have an infant more than 6 months of age traveling to high-risk countries, MMR vaccine should be given before traveling, but this dose doesn't count. Means that they have to receive the routine immunization of MMR at 1 year and at 4 years, means 2 additional doses. What is the most reliable test for measles or rubella? Measles immunoglobulin IgM serology. If you have non-immune pregnant woman, infant less than 12 months, severely immune compromised, exposed to measles, immunoglobulin should be given within 60 days of exposure. MMR vaccine can be given in place of immunoglobulin if administered within 72 hours of exposure. Measles is contagious 4 days before the rash and 4 days after the rash. Measles can complicate with acute encephalitis or even death. A rare complication may appear later in life, 7 to 10 years after subacute sclerosing panencephalitis. Vitamin A is recommended to all patients with measles regardless the country of origin. Posterior auricular suboccipital lymphadenopathy, headache, eye pain, throat pain, maculopapular rash, low-grade fever, and chills. What is the most likely diagnosis? German measles or rubella. Parotid swelling, low-grade fever, and not ill-looking. What is the most likely diagnosis? Mumps. If the child is toxic-looking, think about bacterial causes. Possible complications of mumps in boys: epididymoorchitis, meningitis, and pancreatitis. Sudden onset of fever, chills, headache, malaise, diffuse myalgia, non-productive cough, followed by sore throat, nasal congestion, rhinitis, and cough during the winter season. What is the most likely cause? Influenza. If you have a child presenting with sudden onset of fever, headache, body aches, chills, ill-looking, inability to walk, or tenderness of calf muscles, or myositis or myocarditis during influenza season, this is influenza. It is a clinical diagnosis. Confirm with rapid detection of influenza antigen test, and the treatment is mainly supportive with few exceptions. Rapid influenza detection test has a 76 false negative results, and the sensitivity varies according to the timing of the year and the peak of influenza. Early and aggressive treatment action should be taken in patients with a high clinical suspicion of severe influenza infection. Simply, the patient can die from influenza myocarditis. Oseltamivir or Tamiflu is indicated in high-risk patients, for example, patients with underlying cardiac or pulmonary diseases, severe cases, or children less than 2 years of age. Fever, runny nose, barking, brassy or seal-like cough, and stridor. What is the most likely cause? Parainfluenza virus is the most common, but also can be caused by other viruses, for example, influenza. Treatment is supportive most of the cases. Corticosteroids help and lessen the severity of the illness and decrease the chance of hospitalization. Racemic epinephrine for severe airway obstruction. It is critical to be able to differentiate Croup, which is viral, from bacterial tracheitis, which is bacterial. In case of Croup, the child will be not toxic appearance. In case of bacterial tracheitis, the child will look toxic and very ill. Mild to moderate respiratory distress, severe respiratory distress, usually not rapidly progressive, usually rapidly progressive. Parainfluenza is the most common cause. Staph aureus is the most common cause. Usually normal white blood cell count when you do CBC. Here the white count will be elevated. Usually positive steeple sign in frontal view of neck x-ray. However, this can be normal variation in children. Irregular tracheal margin on the lateral chest x-ray, which is a purulent tracheal membrane. The treatment here is supportive. Here airway support, for example, endotracheal intubation and anti-staph antibiotic. 10 months old presents with fever, runny nose, cough, poor feeding, nasal flaring, tachypnea retractions, wheezing, crackles, and low oxygen saturation during the winter season. You decide to perform a chest x-ray and it shows peribronchial fullness and hyperinflation of the lung because of air trapping in the peripheral lung. What is the most likely cause? Respiratory syncytial virus acute bronchiolitis. Transmission of RSV virus by direct contact, and the best way to prevent the spread of the virus by hand washing. RSV bronchiolitis is a clinical diagnosis. There is no need for lab or chest x-ray to make the diagnosis of RSV, bronchiolitis. Rapid diagnostic assay can confirm the diagnosis, and the treatment is mainly supportive. Means there is no need for albuterol, no need for inhaled or oral steroids, no need for antibiotics. So it means hydration, providing oxygen if is required. Albuterol can be given or as a trial if the family history is positive for asthma and the child is responding. RSV prevention is required during RSV season with monoclonal antibodies or palivizumab or Synagis. In cases of preterm infants, infants with chronic lung diseases and congenital heart diseases. If you have the classic presentation of acute bronchiolitis and RSV is negative, what is the most likely cause? Human metapneumovirus is the second most common cause of acute bronchiolitis. It is difficult to distinguish acute bronchiolitis caused by human metapneumovirus and RSV. Since the management is the same, testing is not required. Unimmunized, the presence with fever, muscle weakness, and paralysis involve the proximal muscle first, loss of reflexes. What is the most likely diagnosis? Acute poliomyelitis. 2-week-old with microcephaly, poor feeding, hypotonia, hepatosplenomegaly, jaundice, chorioretinitis, passed the newborn hearing test, thrombocytopenia, skin rash, and cerebral calcifications on CT scan. What is the most likely cause? Cytomegalovirus infection. Critical points to remember about congenital cytomegalovirus: microcephaly, sensorineural hearing loss, even if the infant or newborn passed the newborn hearing screen. These infants, they may develop the hearing loss over the years, and they need follow-up every year with audiologists until at least they are 6 years of age. Cerebral calcifications. In cases of cytomegalovirus, the cerebral calcifications is periventricular, periventricular. In cases of toxoplasma, will be diffuse all over the brain, or diffuse cerebral calcifications. Very important to know the difference. So cytomegalovirus, periventricular. Diagnosis of congenital cytomegalovirus infection during neonatal period by detection of CMV, by ordering CMV urine culture, oral fluids, respiratory secretions, blood or CSF CMV culture, obtained within 2 to 4 weeks of birth. Strongly positive CMV specific IgM antibodies during early infancy can be suggestive of congenital cytomegalovirus infection. Treatment of congenital cytomegalovirus infection is ganciclovir for symptomatic patients for 6 months. Follow up with CBC because of high risk of neutropenia. This is critical. If you have a child or adolescent with unexplained fevers, generalized lymphadenopathy, hepatomegaly, splenomegaly, failure to thrive, persistent or recurrent oral and diaper candidiasis, recurrent diarrhea, central nervous system disease, parotitis, hepatitis, lymphoid interstitial pneumonia, recurrent invasive bacterial infections, and other opportunistic infections, for example, viral and fungal. What is the most likely cause? Human immunodeficiency virus, HIV. Diagnosis of HIV infection depending on the age. Less than 2 years of age, the classic is HIV DNA polymerase chain reaction, or PCR, at 2 weeks of age, then repeat again at 1 to 2 months, and then repeat again at 4 to 6 months. And if you order antibodies less than 18 months, this will reflect the mother and is not helpful in the diagnosis. Children older than 2 years or equal 2 years, you can order ELISA if it's positive, followed by Western blot. Important points to know if you attend a delivery of a newborn to a mother with a positive HIV. No breastfeeding is contraindicated. Also, zidovudine has to be started as soon as possible, within 12 hours for at least 6 weeks. And no live vaccine to children with HIV who are immune compromised, means that the percentage of CD4 and T lymphocytes is less than 15%. This is critical to know. What is the main side effect of zidovudine? Bone marrow suppression. If you have a child with stiff neck, fever, CSF white blood cell less than 1000, 80% neutrophil in the beginning, negative CSF gram stain, and negative CSF and blood culture, what is the best CSF study to order? Add enterovirus PCR to CSF studies. Enteroviral meningitis or viral meningitis in general may present with high percentage of neutrophil in the beginning, but later on the percentage of lymphocytes in the CSF will be predominant. This is important to know and is very distracting in the vignettes. Recently traveled to Africa. Now presenting with high fever, chills, rigor, sweats, and headache. What is the most likely cause? Malaria. This is a classic presentation of malaria. Fever is paroxysmal every other day or every third day. Every other day, like in case of Plasmodium falciparum or Plasmodium vivax or Plasmodium oval. Or every third day, like in case of Plasmodium malariae. But practically speaking, in real life, this pattern of fever infrequently seen in children. Recently traveled to Africa presenting now with seizure, decreased the level of consciousness, retinal hemorrhage, and hypoglycemia. What is the most likely cause? Plasmodium falciparum or cerebral malaria. Plasmodium falciparum can be associated with cerebral malaria, which is seizure, coma, and death. High parasitemia or high burden of parasites in blood can cause anemia, hypoglycemia, hypotension, decreased tissue perfusion, metabolic acidosis because of lactic acidosis as a result of decreased tissue perfusion, hepatorenal failure, pulmonary edema, vascular collapse, shock, and death. If a child travels to Africa, what would be the prophylactic antimicrobial therapy of choice for malaria B? If the area is chloroquine-resistant Plasmodium falciparum malaria, the recommended prophylaxis is mefloquine or atuvacone briguanil or doxycycline. The prophylaxis or the medicine should be started before arrival. For example, 2 weeks for mefloquine, 1 to 2 days for atuvacone briguanil or doxycycline. Visiting or living in Mississippi, Ohio, Missouri River valleys, presenting with fever, chills, non-productive cough, malaise, hepatosplenomegaly, diffuse nodular infiltrates, hilar lymphadenopathy. What is the most likely diagnosis? Histoplasmosis is the most likely diagnosis. Your key words here, Mississippi, Ohio, Missouri River valleys, the location where the patient will be exposed to bird droppings. Mild cases will be flu-like symptoms like fever, chills, non-productive cough, malaise, and hilar lymphadenopathy. This is important. And in severe cases, progressive disseminated histoplasmosis, they will have fever or prolonged unexplained fever, failure to thrive, and hepatosplenomegaly. Also, they can have more severe symptoms depending on the underlying condition. Diagnosis of histoplasmosis culture is the definitive method of diagnosis. Serology tests for subacute and chronic cases. Cases of histoplasmosis are self-limited. Like mild to moderate cases, the treatment is only supportive. If no improvement after 4 weeks, you can try itraconazole. In severe cases like disseminated infection, amphotericin B followed by itraconazole. Another case can be confused with histoplasmosis if they mention a child living in California or visiting California, Arizona, West or South Texas, presenting with fever, chills, weight loss, cough, shortness of breath, night sweat, bronchial breathing, tender erythematous nodules on the lower extremities, or erythema nodosum, lung nodule or cavitary lesion on chest X-ray, and elevated ESR. What is the most likely diagnosis? Coccidioidomycosis. The buzzwords here, the location, for example, California, Arizona, West or South Texas, plus non-specific manifestation, for example, fever, cough, chills. Other manifestations, very important to remember about coccidioidomycosis is erythema nodosum or erythema multiforme. Also, they may present with asymptomatic lung nodule or cavitary lesion or coin-like lesion on a chest X-ray. And if they mention one of these location plus asymptomatic lung nodule or cavitary lesion, you have to keep coccidioidomycosis in differential. Best diagnostic test for coccidioidomycosis is serologic testing. The good news that most of the cases of coccidioidomycosis are self-limited and will resolve without therapy. In severe cases, you can give fluconazole or itraconazole. If you have a child with history of leukemia or lymphoma receiving chemotherapy, or children taking corticosteroids, children with congenital immune deficiency or acquired immune deficiency syndrome, presenting with meningitis like symptom like fever, headache, behavioral changes, and the CSF culture or bacterial culture is negative. What is the most likely cause in this case? So the keywords here, immune deficiency plus meningitis and negative CSF bacterial culture. Cryptococcus neoformans. The best test is CSF for a Cryptococcus antigen. If it's positive, this will confirm the diagnosis, and the treatment is amphotericin B. Be familiar with the electrolyte disturbance associated with amphotericin therapy. It is hypokalemia and hypomagnesemia. History of atopic dermatitis or eczema, asthma, taking inhaled steroids, presenting with intermittent fever, recurrent episodes of cough. The cough is productive with dark brown mucus plugs. Not responding to usual treatment of asthma, elevated eosinophils and high level of IgE. Chest radiographs shows upper lobe parenchymal opacities, atelectasis, and central bronchiectasis. What is the most likely diagnosis? Allergic bronchopulmonary aspergillosis caused by Aspergillus fumigatus, and the treatment is oral corticosteroids. This condition will not respond to inhaled steroids. Keywords here to look for in the exam and in real life: history of asthma, recurrent episodes of cough, and the cough is productive with dark brown mucus plugs, not responding to usual treatment. This is very important and is a red flag for underlying condition, not the asthma itself. Elevated eosinophils and elevated IgA level. This is really important to know. Travels to resource-limited countries, presenting with cough, abdominal pain, vomiting, intestinal obstruction, or appendicitis. What is the most likely cause? Ascaris lumbricoides. Intensely pruritic feet or hands for 2 weeks, cough, iron deficiency anemia. What is the most likely cause? Human hookworms, for example, Ancylostoma duodenale or Necator americanus. They penetrate the skin and they can cause itchiness at the site of penetration, and they suck blood from the intestine and they can cause iron deficiency anemia. Intense perianal itchiness, especially at night. Pruritus vulvae in girls. Grinding of teeth at night, weight loss, and enuresis. What is the most likely cause? Pinworms or Enterovirus vermicularis. Fever, leukocytosis, eosinophilia, hypergammaglobulinemia, wheezing, abdominal pain, hepatomegaly, exposure to dogs and cats. What is the most likely cause? Toxocariasis, caused by Toxocara canis or Toxocara cati. Exposure to dogs and cats, this is the key. Look for eosinophilia, look for wheezing, abdominal pain, and hepatomegaly. These are the key points for toxocariasis. What is the treatment for all these types of worms? Albendazole can be used for the treatment of all these types of worms. History of travel to South America, presenting with muscular pain, severe headache, and recurrent seizures. You decided to order a brain MRI and it shows multiple ring-like lesions in the brain. What is the most likely diagnosis? Neurocysticercosis. Cysticercosis is a tapeworm disease caused by Taenia solium, which is a porky tapeworm. Taenia solium produces lots of larvae or cysticerci, and cysticerci larvae can be anywhere in the body, in the brain, in the eye, in the spine, in the muscles, and can cause complications. In the brain can cause seizure or even hydrocephalus. So the treatment in this case is focused in controlling the seizure by giving anti-seizure medicines, and the placement of shunt is associated with hydrocephalus. Most of the experts, they recommend treatment with albendazole for patients with non-enhancing or multiple cysticerci. Before deciding to treat with albendazole, you have to send the patient for eye exam to rule out any cysticerci in the eye. Concomitant treatment with corticosteroids may decrease the adverse effects, especially if there is multiple viable larvae in the brain, and will decrease the inflammation. Treating by albendazole by itself in this case may exacerbate the seizure and make it worse.